Annapoorna Kini and Mike Gibson coming to you live from ACC 2023, and we are talking about an exciting new study, Yellow 3. Talk to us, Dr. Kini, about Yellow 1, Yellow 2, now what you've done in the Yellow 3 study.
Okay, thank you for this opportunity. So we started the Yellow series almost 12 years ago. Essentially, my goal was to understand who are the patients who develop lesions despite giving them good medical therapy, or have they after having stent procedures. So what did we do in Yellow 1? At that time, we randomized to high dose statin and low dose statin, and just took all comers and imaged them just with IVUS and NIRS to understand what the plaque composition was. So then we found out that high dose statin, which is aggressive therapy, was the one that actually decreased the lipid content as with by NIRS. And we also found 30% of the patients, since we took all comers, had no lipid, means they were end stage disease. So these are the two things we learned. One, that you need aggressive therapy. Two, you need to focus on patients who really have lipid. So then when we came to Yellow 2, randomization was not an option. Everybody had to be on aggressive therapy. So then we went to the next step. What actually happens in these patients? How is that cholesterol coming out of that plaque? So we thought the so-called LDL molecule is very important, and cholesterol efflux is the one that is going to help for this lipid to come out. So in what we did in Yellow, at that time, the new other imaging, which is optical coherence tomography, was also available at that time to understand what was the cap thickness. And a lot of other studies were going on talking about stable plaque, unstable plaque. The cap was very important to understand who is stable and who was unstable. So in Yellow 2, when we came, no randomization, high dose statin, we did cholesterol efflux on this patient at baseline, at follow-up. We did OCT and we did NIRS. And what we found was very impressive, that what actually improved the fibrous cap thickness was what their baseline fibrous cap thickness was, number one. Number two was people who had a good efflux, essentially saying that LDL molecule is also important to improve that. But from also what we added was that just by doing clinical parameters, imaging is not going to help us. What actually happens in a person's body? So we went and did what is called as a transcriptomic evaluation, means gene expression on these patients at baseline and at follow-up. And at follow-up, we definitely found of our 117 genes, 5 important genes were the one that were upregulated, couple were downregulated, and most of them were cholesterol metabolic inflammatory genes and gene related to cholesterol efflux also. So this was the 3 things that very important that we found, but all patients were on statin. Now, as we move on, PCSK9 came into equation. So then we came to the fact, are there patients? We know patients with statin respond. We know patients should get PCSK9. Now, who are those people? Who can we identify them? So that is when we came to Yellow 3. So now when we came here, we wanted to be very clear who are the patients we need to enroll. Means they had to have lipid plaque. So they had to have what we call as patients who are on statin for minimum 4 weeks, okay, on either a moderate or high dose statin. So they had to have certain number of LDL criteria before we can enroll them. So after having, we had to identify non-obstructive lesion. Yellow 1, Yellow 2, we did obstructive. Now we came to non-obstructive lesion. In non-obstructive lesions, we had to do OCT and make sure that there was fibrous cap that was not too thick. So we had a criteria of FCT thickness of 120 micron. So anything less than that, we had to include, and we had to make sure the lipid arc was more than 90 to make sure these were lipid plaques. And after that, we did the NIRS. So NIRS number was not inclusion criteria. All of them got Evolocumab twice a month, means every 2 weeks for 26 weeks. When they came back, we did the imaging of that same segment again. And then we did the blood work again to get that transcriptomic. So imaging data is the one that I'll be presenting in the ACC to say that, yes, first time we are presenting the same findings that has been done with Evolocumab on ACS patients. All the other trials were ACS patients. We did it on the stable coronary artery disease patients. So very interesting is that even on stable CAD patients, we found 48% thin cap fibroathyroma, saying that these patients who are on statin, that is, will still have this plaque who can have events. And we know that these patients who are on statin still have events, and this probably is the reason. So LDL definitely improved, fibrous cap became thick, significantly improved. All the clinical parameters, which included LDL decreased and HDL improved. We all know that CRP does not change, and that's the same thing we found, that at baseline and follow-up, CRP never changed, and LCBI also changed. Now, we also had IVUS, so plaque PAV, which was percent atheroma volume, improved by about 1.3% in this group. So these are the key findings of Yellow 3.
So what does it mean for us out there as practicing doctors, Dr. Kini? How do we integrate this into practice? Does it give us reassurance about the benefits of PCSK9 inhibitors?
Very important question. That question will be that should they all go on a statin, or should they all go on PCSK9 from the beginning? Have been clinicians, okay, and know the guidelines now. They say LDL has to be less than 55 and is lower the better. All these things, multiple questions are there. And we have seen just being on statins to get LDL less than 55 is very hard. So this is where I think the future, or all we clinicians have to be thinking that as a secondary prevention, what should be the level be? If we think it's 55, then is that we need to find a group of patients who are the ones who probably need PCSK9 directly. And that is what I think we will be able to provide, knowing we have data from Yellow 2 gene expression, and we will have the genetic data of the transcriptome data from here of Yellow 3. We may be able to come out with find some kind of a deep learning, machine learning model to understand who are these patients that don't, who do not respond, and who should be getting one kind of therapy. And that is what our goal is, that once we will be analyzing all that work.
Well, I was excited to hear your comments about cholesterol efflux and its impact. As you probably know, I just finished enrolling 18,000 patients in a trial where we're giving ApoA1, which we know will improve efflux, to see if that improves outcomes after heart attacks. So it'll be interesting to see if we can alter the course of the natural history and secondary prevention by improving efflux. Well, thanks, Dr. Kini. Great. I always have been a big fan of your Yellow studies. Thanks for sharing with us today. And thanks to all of you for joining us here live from ACC 2023.
Thank you.